Jerome, thank you very much for your welcome, and good afternoon, everybody who's been able to join us for this happy hour session. If this is your first time that you've joined the Housing LIN and one of our happy hour sessions, just by a brief introduction, it's a concept that we introduced last year as lockdown was facing all of us, and unfortunately we had to suspend all our regional network meetings, and we very quickly went digital. And the Happy Hour brand has been created, and we now run these very frequently, normally on a Thursday afternoon. And if you don't know, HAPPI stands for Housing Our Ageing Population Panel for Innovation, and it's something that the LIN is very closely associated with. So really pleased that we can continue engaging and networking, albeit online, with our members as well as the associates engaged with the Housing LIN. This afternoon's session, as Jerome said, is really focusing on the interface across housing, health and social care. And we've got three excellent sessions for you with four speakers. We're going to look at, first with Matt Carter, who's the Senior Delivery and Policy Manager in the Anticipatory Care team at NHS England, on the work that's been taking some time and is coming to gestation around thinking about what does anticipatory care mean and what it is for our primary and community health services, but in particular about how it interfaces with housing. For many of you, Neil Reevely will need no introduction. He's a long-time friend of the Housing LIN, and we've worked closely together on a number of projects around integrated care. And he's going to talk more about how this fits in with the agenda around engaging and building those strategic partnerships. He's got a wealth of experience, both as a Director of Social Services, but also working with the LGA and ADAS, where he's the co-chair of the Housing Policy Network. And as Jerome said, we also this morning launched a really important piece of work as a case study that captures some of the lessons and learning from an exciting little project that has been undertaken between Octavia Housing Association in West London and St Christopher's Hospice. So I'm really pleased again we've got another Neil McCarthy, and the Senior Associate at St Christopher's, Liz Bryan, who are two of the co-authors of this case study. And there's some really interesting learning, not just about extra care housing generally, but also extra care housing in relation to later life and end of life care. So again, the relationships with health and social care being very important components of that. We'll then have an opportunity for questions and answers, and please do post your questions as we go along in the Q&A box. If you have general chat, please use that, as Jerome has indicated, and any problems, do let the team behind the scenes know. So without further ado, can I give a warm welcome to Matt, and the Housing LIN's been associated with the Anticipatory Care team. I've been really pleased to be part of the advisory group, so it's great. I know you've got a really busy programme of external online events at the moment, so thanks for taking the time to join us this afternoon, Matt.
Thanks, Jeremy. I'm just going to share my screen. Is that sure? Can we see that, Jerome? Yeah.
That's great. Yeah, we can't see you though. I think your video is switched off.
Yeah, my camera switches off once I start sharing.
All right. Okay. Thank you.
So yeah, once again, thank you, Jeremy, and hi to everyone on the call. As Jeremy said, I'm Matt Carter, Senior Delivery and Policy Manager for Anticipatory Care within the Anticipatory Care Programme. By way of introduction to us, the Anticipatory Care team is part of the Discharge and Community Services team at NHS England and NHS Improvement. And it's an absolute privilege to be speaking to you all today, and it's great to see so much energy and interest in anticipatory care with so many of you here. I sincerely hope that this will be a useful, informative session for you all. We've been on a long journey since the NHS long-term plan was published in January 2019. And as Jeremy said, we've been working with a wide range of stakeholders in that time to develop and shape the direction of anticipatory care ready for delivery this year. So let's get on to the meaty stuff. What is anticipatory care? So Anticipatory care in a nutshell is proactive care and support targeted at people living with frailty, multimorbidity and/or complex needs, and this is to help them stay independent at home in adequate housing and reduce ill health for as long as possible. It focuses on what is important to the individual, building on personalised care approaches to ensure that the proactive care offered to these populations is based on what matters to them and considers their needs holistically. Anticipatory care is delivered and coordinated through multidisciplinary working. In its simplest sense, anticipatory care should drive integration between providers of primary and community care services to improve coordination of care and improve experience. It's about making sure that care wraps around complex individuals who need that coordinated support, taking into account what their wishes, ambitions are around ageing well. At its most complex, when we think about ambition setting, it's an equal seat around the MDT table for whatever and whoever matters to that individual. And this could be physical and mental health teams, social care, community pharmacy, voluntary sector, housing sector, and other community partners. So at its most mature state, it's truly cross-sector and integrated. The overarching vision for the programme is to reduce the need for escalation of care to non-home settings, such as hospital or care homes by 2022-23. And we know for some areas, proactive MDT care is nothing new, and it's important to recognise that there are a lot of areas already out there exemplifying this way of working. And as I said, AC is already out there in some areas. The work that we're doing nationally does not intend to duplicate or override existing arrangements where they are already in place and working well. Rather than that, it's intended to support areas not working in this way currently by providing a standardised approach to using an existing resource. And this includes through committed long-term plan and other funding to develop and strengthen relationships locally, which will enable this type of care to happen. And so one last thing on the what side of this slide, which is incredibly important to highlight. Anticipatory care is for people living within their own homes. It's not intended to duplicate or cross over with our support offer to care homes through the Enhanced Health in Care Homes framework, and is available for all age groups. There are no limits to over 65s, for example. Anticipatory care is about supporting complex populations to age well. So I've covered the what and a bit of the how, but now more on the how. There's obvious alignment and synergies with other national programmes and services such as the Urgent Community Response within the Ageing Well programme at NHS England, Discharge to Assess, which supports the timely discharge from hospital settings, community mental health programmes, the Better Care Fund and Disabled Facilities Grant, NHS Continuing Healthcare and Personal Health budgets, along with, of course, Council's Care Act responsibilities. It's intended that the suite of support and funding will, in its totality, support areas to deliver a proactive, preventative, personalised approach to care and support, enabling people to remain independent in adequate housing for as long as possible and avoid those preventable crises. Given the last 16 months, it'd be really fair of people on the call to say, why now? And well, the NHS long-term plan set a clear ambition for us within the NHS to be more joined up and coordinated and dissolve the historic divide between primary and community services, as well as broader across health, social care, housing, voluntary sector. Anticipatory care is a core element of achieving both this and the long-term plan's commitment of supporting people to age well. It's based on our learning from programmes such as the Vanguard multi-speciality community provider model, the Better Care Fund, as I've mentioned, improving health and care through the home MOU, year and house of care, and people-powered health. We believe that we've got a real opportunity to harness some of the ways of working, thinking and collaborating that COVID has forced. And of course, we then come on to the why column on the far right. It's a quadruple aim, I'm sure you'll all expect to see, but it's about improved population health through supporting proactive models of care. anticipatory care is about improved experience of care resulting from coordinated, personalised care and support. It's about improved staff experience, the type of care we hear loud and clear professionals across all sectors want the time and licence to deliver, and finally delivery of high quality care to the right place, the right time and in the right setting. It's nothing unexpected, but at the same time absolutely crucial to individuals, staff and us here within the policy team. Happy, healthy, independent populations supported to age well in adequate housing. So in practice, anticipatory care is delivered through 5 key steps. The first being population cohort identification. So this is using risk stratification to identify the cohort most at risk of unwarranted health outcomes. So once this is identified, the next step is a proactive care needs assessment. And this is to undertake a proactive the assessment in a personalised, holistic manner, which will determine the individual's health, social, housing and support needs. So once the assessment's taken place, it moves on to personalised care and support planning, which is understanding what matters to the person as well as their clinical and support needs, including housing. After that, you've got your digitally enabled multidisciplinary teams, which are essential to delivering optimum anticipatory care. This is multi-agency, including housing, and should vary person to person, depending on their need. And finally, the last key step is care coordination, which is building on the personalised care and support planning. It's to bring together all the identified information and recommendation for the person's care and support needs. And it's working with the person and their representatives to coordinate the care and support that they will receive. And then all of these different key steps are underpinned by 3 enablers. The first being developing system working across all partners. The next being sharing of relevant data across organisations and sectors and resolving any issues associated with this. And the last is implementation of digital tools, both for the person and the professionals where appropriate. So what does a journey through anticipatory care look like for a person? So this is Mos journey through anticipatory care. Mo is 60 and lives at home with his wife Pfizer. He has been a finance manager for a construction company for the majority of his career. The job hasn't involved a lot of moving about, which has contributed to his ill health, which includes type 2 diabetes, hypertension, severe obesity, and issues with mobility due to his weight and diabetes, which has meant he has voluntarily taken early retirement. Mo wants to get fitter and lose some weight to enjoy his retirement and be able to walk to Friday prayers like he used to before his conditions escalated. So Mo's journey firstly starts with a cohort being identified by the primary care network. For this example, the cohort identified would be all adults with diabetes, hypertension and a BMI of over 35, which Mo falls under this cohort. Next, Mo is offered a proactive care needs assessment, which Mo accepts, and it's then carried out by the best placed person for him. In this case, it's his diabetes nurse, who he has been seeing regularly to get his diabetes under control. His wife Pfizer is present and contributes to the assessment. After the proactive care needs assessment is conducted, a what matters to me conversation takes place with Mo to fully understand what his goals, outcomes for his health and care are. Again, Pfizer is part of this conversation, allowing her to feel able to contribute to Mo's care. Then, once this conversation has taken place, a multidisciplinary team will meet to discuss and agree interventions for Mo's care. Mo's MDT is tailored to him and his needs. So in his case, it includes his GP, his diabetes nurse, who's employed by the local community provider, a social care occupational therapist to assist with the assessment for housing adaptations that will be needed, a home improvement agency to support with the required housing adaptations, a podiatrist because his proactive care needs assessment identified he was struggling with his foot health because of his diabetes, a dietitian for his weight, and a community physio for his mobility. Once the MDT have met, a named care coordinator will coordinate the required care and support whilst involving Mo and Pfizer. In Mo's case, this is a primary care network care coordinator. The care coordinator and Mo's diabetes nurse will have regular reviews with him to see how he's getting along and how his health and care and support needs are progressing. So as a result of the care that's put in place, Mo is more comfortable, along with Pfizer, in managing his diabetes himself. His blood pressure is reducing, and Mo is progressing to self-management for this. The condition of his foot is improving. He's slowly started to lose some weight. His adaptations made to his house so he can get around more easily. And now he feels more confident in walking to Friday prayers. So I hope that. So thank you for listening. I hope that's given you an insight into what anticipatory care is and the important role that the housing sector plays. If you want to know more or get more involved in the anticipatory care work, then you can head to our Future NHS platform, which are the links on the slide. You can join our community of practice, which is a new forum that's been set up quite recently. That includes colleagues from across health, social care, voluntary sector, housing, etc. And details on this can be also found on our Future NHS platform. You can follow us, myself and the team, on Twitter, so at McCarthy NHS and at Aging Well NHS. And then finally, you can also join the conversation on Twitter using #AnticipatoryCare. Once again, thanks for listening.
Matt, thanks ever so much for that really good sort of tour of the situation, the landscape around anticipatory care, and also personalising it through a sort of a persona as well. I know that we've got several questions already coming up in the Q&A. Rather than answering them or typing them, can I come back to you later and we can go through Kim and Joanne's queries? Some interesting points being raised already, and please, I encourage everybody else to put their responses and questions in as well. But thanks ever so for joining us now, and look forward to coming back to you shortly once we've heard from Neil and Liz. So Neil, are you there?
I am.
Welcome, and as I said in my introduction, you've been a long-term friend and supporter of the Housing LIN, and I'm really pleased that you're able to join us this afternoon. And what people won't know is Matt talked about the MOU. You were a key person in the creation of that originally, so you have real good first-hand knowledge of that sort of partnership working. So over to you.
Thanks very much, Jeremy. And as you know, we see ourselves, we being either the LGA and or ADAS, the Association of Directors of Adult Social Services, as a partner with the Housing LIN, and we've long since been partners, and we see that whole system approach and certainly the work of the LIN adding to that. First of all, I think people might spot the deliberate mistake on my opening slide. I think I got the wrong date on there, so on the 4th of June. I think it's the 3rd of June, so apologies for that. So as Jeremy said, so I am in effect representing both the Local Government Association and the Association of Directors of Social Services, and I'm struggling to move my slides on.
If you just click on your right tab on your keyboard, the right arrow.
I'm trying that and it's not working.
It's not working. Try to just click on the screen then.
Oh, there we go.
There we go.
I think that's worked. So I don't want to dwell on some of these slides, the introductory slides in particular, just for people who don't know, the Local Government Association, being the national voice of local government, it's a politically led but cross-party organisation, and I think virtually all, there might be one or two local authorities who aren't members of the LGA, but in effect virtually all local authorities are members of the LGA, and we as the LGA support overall improvement. And within that overall improvement, there is a programme called the Care and Health Improvement Programme, which is the programme I am part of within the LGA. And this programme is commissioned by the Department of Health. So they pay for the programme, if you like, but it's delivered jointly by the LGA and ADAS, although it's hosted by the LGA. And we've just had that renewed again for this forthcoming year and beyond. So just to say that this programme is aiming to support improvement overall and support that in the overall integrated work with which the anticipatory care work is indeed part. You'll see on the third sort of line down there, or the third section down there, regional support via care and health improvement advisors. That's what I do mainly, but actually I then have an additional role, which is as the housing lead for the programme. You'll also see in that section the BCM, which for those who don't know stands for the Better Care Managers and the Better Care Fund, the BCF. And the BCF is a joint programme with NHS England, NHSE and NHS England and Improvement, and the housing also plays a major part in that. So people may recall there is something called the high impact change model, which used to have 8 elements to it, which advise people on the big high impacts that could impact and help and change and improve how people could be discharged from hospital. And people were loath to change it once it was set up, and they had 8, as I say, 8 particular high impact changes, but there was a 9th one added just before the pandemic, the year before the pandemic, and that is housing. So the 9th high impact change is around housing. So there's a whole section on that, and if people aren't aware of it, it would be useful for you to get hold of the high impact change model and look at that 9th element around housing. About to be published, which following this session I can ensure the LIN has a copy of. It's not quite published yet, but will be published imminently, is to be in effect a high impact changes for preventing admission. And of course, anticipatory care and housing issues clearly will form part of that. And we're already in discussions about how we perhaps could add some specific high impact housing changes that we can add to, in effect, the suite of support we're giving across health and social care. So in my chair standing for Care and Health Improvement Advisor housing role, it is about promoting that joint work across adult social care, health, housing, using the Memorandum of Understanding that's already been referred to. It provides a direct link to the Department of Health and Social Care and the Ministry of Housing, Communities and Local Government, as well as linking into the national housing organisations that you would recognise, including, of course, the LIN. We and I support regional approaches within ADAS branches. So Directors of Adult Social Services form regional branches based on local government regions, and we support those regional branches with housing strategies, of which the LIN quite often plays a big part. We also work with individual local authorities and individual Directors of Adult Social Services and their senior team on housing opportunities. We support strategic approaches across local authorities and corporate engagement, advice on strategy development and sharing examples of good practice. And as you can imagine, we draw heavily on the LIN, who is basically, as far as we're concerned, quite often the best place to find those examples and those good practice. So that's a bit about the role, and the reason I've put that there is why that role potentially is important as we take forward some of the things we'll talk about today in terms of anticipatory care, but linking to other opportunities, which I'll come on to in a minute. So for those who aren't familiar with the National Memorandum of Understanding, I hope there's virtually nobody who's listening. We would like to think that you're all very much aware of it. So this was initiated by NHS England back in the day with the housing and care sector. It was originally published in 2014 and stood as government policy, but we refreshed it in March 2018. Mainly, to be honest, to make sure it could continue to stand as existing government policy. We didn't want it to stand as former government policy from 2014. We wanted it to stand as government policy, which it did, and it was hosted particularly by Public Health England within the .gov and the NHS sort of the government website proposal. So Public Health were taking a lead on our behalf, but ADAS was seen as holding the ring, if you like, to ensure the Memorandum of Understanding could continue to be used and refreshed and so on. So we tend to think of this, and I know Jeremy will always support us on this and uses it as well. We tend to think of this as sort of the umbrella. If you're trying to set up something locally in a strategic sense with the various agencies, so the Memorandum of Understanding doesn't make anybody do anything, but it sets out what all the organisations in effect have signed up to and recognise as good practice, and that includes all the government agencies, so MHCLG, Public Health England, Department of Health and Social Care, but also the Local Government Association, all the various major national housing bodies, people like Skills for Care as well, all those sorts of people. So in effect, it provides the air cover, if you like, or the way in, when I would be advocating for many people on this webinar, really, as you make, push open the door if you need to start making those strategic approaches locally. We would always advise using the Memorandum of Understanding to say, actually, whoever you're talking to, their parent organisations will be signed up to making housing integrated with health and with social care. So that's why we believe it's important. So in relation to anticipatory care, what are the opportunities? Well, I think one of the biggest opportunities is that this sits along a suite of other things. It isn't just anticipatory care on its own. Anticipatory care is born out of the NHS plan, as Matt has previously talked about. And there are other things in the NHS plan, and of course there are other things that we'll refer to now, not least the reform of social care, where anticipatory care sits as part of, and I've already mentioned the Better Care Fund and how that works in relation and how that interfaces with anticipatory care. So it isn't just that this is an opportunity for housing colleagues to sort of join up in the way that many of us have wanted to for some time on its own. It's actually part of a suite of things that we need to take those opportunities. So the engagement with ICSs and primary care networks. So people might be familiar, obviously, with the legislation that is now embodied, that ICSs are the sort of structural governance framework within the NHS. And they are of varying sizes. So, for example, the one I interface quite often with is in the Northeast, and it actually covers the whole of the Northeast region as far as local government is concerned. Whereas in Yorkshire and Humber, there are 3 ICSs that cover that local government region. But however big they are, it's sort of shades of big rather than small. So the ICSs are the key governance network, and they will build on primary care networks, or the subsidiarity that's meant to be there is around primary care networks. Primary care networks are meant to be based on populations of about 30 to 50,000 people, which the research would suggest and would provide some evidence that that's the sort of place-based population size when you can really get traction at a local level to make a real difference for people and communities. So there's a great opportunity there. I think part of our concern in local government, if I'm honest, is whether we'll be able to get a proper seat at the table in those governance structures, and certainly in the subsidiarity role of ICSs. We are hoping that primary care networks, of course, will be the sort of basic footprint, if you like, that will build up to hopefully local authority boundaries, and we're hoping health and wellbeing boards will therefore provide quite a governance structure that will then link into the formal ICS governance structure. And I'm keen to help and work with, as I said before, regions, local authorities, particularly from a local government side of things, to ensure housing gets a proper voice at that table. But the opportunity is there, because we know housing and housing-related services can substantially support the delivery of the national health priorities. And of course, we know it always has done. The biggest single impact on health improvement and public health, if you go way back, was slum clearances and housing issues, and we know housing plays that key part. And of course, through the pandemic, we've absolutely recognised how key home is, and if you live in if you live in a good, comfortable home, it will help both your mental health and deliver physical health services to where you are. And if that's not the case, clearly the opposite is true. So housing-related services can substantially support health. So that potentially is an opportunity to provide a further lever to our health colleagues, because I think, if we're honest, sometimes, particularly from the housing sector, people would suggest we've struggled to get through the door of health. We've always known that we've always could provide such a big difference and wanted to support, but quite often we haven't seen how we could break through into those health structures. Hopefully the anticipatory care framework will give us another opportunity to break in and provide the offer that we do to further support the delivery of the priorities that anticipatory care and the other parts of the NHS plan want to see happen. Social care reform, much talked about and much disappointment when it only achieved, I think, 9 lines, or was it less than 9 lines in the Queen's speech. The national media, responded to that, and we understand the Department of Health and Social Care, and indeed the Prime Minister, still has a key commitment, and behind the scenes with the LGA and with EIRDAS there is work going on that is giving us some confidence that social care reform is going to get quite an airing as we go through this calendar year at least. And as far as EIRDAS and the LGA is concerned, there is an absolute key role for housing. So EIRDAS has published, and you can see it on EIRDAS website, sort of a document that is presented to government that identifies 9 key areas that need to be addressed for social care reform. And one of those 9 key areas is all about housing. And the immediate past president of EIRDAS last year talked about any decision about care can be a decision about housing as well. So housing and housing related support, key in social care reform. I have to say we've had some encouraging feedback and noises, if you like, from the Department of Health and Social Care. We've heard again, a bit of a rumour that in the not too distant future we might hear some more about the role of housing in social care, even before some of the social care reform areas sort of announced and consulted on. So social care reform, another one of those suite of things alongside anticipatory care and others that provide us this opportunity to get real traction using the MOU, as I've already said, as a sort of an umbrella to help us get where we need to be. And of course, housing should be part of system-wide planning. And again, anticipatory care gives us that opportunity when local systems want to be talking about anticipatory care, want to be talking about how you prevent people needing to go into hospital, as well as how do you support people in discharge. We need to ensure housing is more at that system-wide planning table. And as I said before, building on the lessons learned during the pandemic, and if you needed any, if we didn't already understand, which many of us on this call already did, just the benefit of or the importance of housing and housing related issues to people, both in health and social care, then the pandemic has certainly brought that home to us, in spades, really. So we then need to ensure that housing is included in local joint commissioning. Quite often, the NHS and the NHS plan talks about integration. It first talks about integration of health with health. So, people think about integration, but actually the health system can be quite disjointed, whether that's primary care, community care, primary health care, community health care, secondary health care, and so on. So integrating with itself, but then if people talk about integration, they quite often are talking about health and social care. Whenever people like me talk about integration, we talk about health, housing, and social care, and we need to ensure that can happen, and how we get housing included in those local integrated teams. So Matt talked about that case study, talked us through Mos Journey. Well, actually, the journey sounded great, but actually in many places it's been very difficult for housing to be part of that integrated delivery team. So we need an integrated planning, and then we need integrated delivery, and we need our housing to be there. And the challenges in doing that include, and you'll have many more, but I've just put some down here, particularly thinking about the question I was asked to address, which is how we get strategic partnerships going. The first challenge is really embedding housing related solutions in government policy, and certainly through the LGA and EIRDAS, as I've already said, particularly linked to the reform of social care. We're lobbying hard and have been for some time, and we've seen what we think is quite a chink of light that may see some see that come forward, particularly in the next year. But we need to see the policy statements that more strongly than existingly, more strongly sort of embed housing solutions in the government policy around delivering health and social care priorities. The next challenge, which I've probably already alluded to in talking to the last slide, was engaging senior leaders in health. and people who know me and who I've presented before will know that I talk about building trust and relationships. Systems and the world runs on relationships, not just about systems and processes. And engaging senior leaders is important in that, where great things have happened and where you see great examples around the country and some of the great case studies you'll hear. It's where senior leaders have shown their commitment and driven things through. So we need to spend time and effort engaging with senior leaders in health, and hopefully, as I said before, things like Anticipatory Care and others can give us that further reason to get them to listen to what we're going to do, and then, as I said, build that trust and relationships. But if we're honest, we have to also pose a question to ourselves, particularly if, in this case, thinking of the housing sector, who speaks for the housing sector strategically? So if we want to have that strategic relationship with senior leaders in health, have we got a representative body, or who is going to take the lead? How do we do that? So I think there's an issue here for us in the housing sector around how we get a strategic voice that we can speak collectively, and that will be at all levels. So how can we coordinate the housing voice at a local level? So if we're thinking strategically about ICSs, my example of the Northeast before, that's a whole local government region. Who is it that we would put forward to represent the housing sector generally, to ensure that it's strategically represented in the strategic statements and governance that we'd like to see? And then who will coordinate that housing voice at the local level, if that's a primary care network at that population base of 30 to 50,000, because as we know, there's likely to be several housing organisations involved, several housing providers, but also home improvement agencies, etc., etc. So how do we get that coordination? And I think that continues to be a question that housing colleagues need to address. And of course, ensuring housing issues are included in health and social care planning frameworks and assurance metrics. So when I've talked to the Department of Health, even though we're a bit reluctant to have too many metrics and be judged in lots of ways, it is true that what gets measured gets done. And so if we can actually have in some of the health metrics that they need to have appropriate housing strategies in place, they need to involve the housing sector so that they know how that's going to be involved and how that's going to work, as well as us at our end building the relationships with senior leaders in health, if they are required through the metrics that they get judged by, if you like, to have these things in place, that will be a further lever. And that will be also the case as we see the reform of social care. Our all directors of adult social services involved in setting up, making sure their local plan has all the right things in relation to housing for older people and other groups that need the appropriate accommodation and so on. So they're just some of the challenges linked to some of the opportunities, and I'm a bit concerned I may have gone over time, so I'll stop there.
Well, to be honest, Neil, I was listening so intently, I even forgot about the time, and so my poor chairing, so you exposed that, so thanks for that. But a really excellent presentation and builds on from Matt's, and I think what you do is demonstrate the strategic partnerships are not just around sort of the high-level systems issue, but also that the building the relationships at a local level as well. And I think that sort of blend is really important. And we're going to move on really to think more around the local examples. And we've got a real life case study that's been published today. And while this is focusing on end-of-life care, and a really important element of how we support and enable people to live to end-of-life in their homes, this sort of also, I know from the work as the LIN on the advisory group, engages also with health, social care and other partners locally. So I'm delighted that Neil McCarthy from Octavia and Liz Bryan from St Christopher's can join us. So I'm going to, without further ado, as they say, I'm going to pass over to Neil. I think you're kicking off.
That's correct, thank you, and thanks to the LIN and Jeremy for inviting us today. Good afternoon, everyone. I'm Neil McCarthy, the Assistant Director for Care and Support at Octavia, West London-based housing association. You're probably aware the LIN have just published the Better Lives, Better Endings case study today, setting out our work today in this area, where we've co-produced a development programme for staff. There'll be a full report and evaluation later on in the autumn. So who is Octavia? So we're a West London-based housing association. We take the name from Octavia Hill, who many of you will know as housing associations, and just lifting a quote from her: to make individual life noble, homes happy, and family life good. And we felt there was a lot of synergy with St Christopher's Hospice when we started on this project back in 2017, and I'll just hand over to Liz to talk about St Christopher's Hospice.
So I'm Liz Bryan. I'm a palliative care nurse by background, and now palliative and end-of-life care educationalist. I'm working as an associate now for St Christopher's Care, which is the new Centre for Awareness and Response to End of Life. And yes, we did. We felt that these two great women had a lot in common. So Cicely Saunders founded St Christopher's in 1967, so over 50 years ago. Again, we've used a quote: you matter because you are you, and you matter until the last moment of your life. A nurse, first of all, then she trained as a social worker, then she became very aware of the lack of expertise around managing dying, particularly in hospitals, and she went off and trained as a doctor, specifically so that she could improve the experience of dying. But she very much saw dying and death involving the whole person, not a medical issue involving just the physical body. So St Christopher's was founded very much on research-based care and then disseminating new knowledge through education. Palliative care is holistic care that focuses on what matters to a person and how they want to live until they die.
So extra care housing, I suppose many of you on the call will understand what extra care housing is. Octavia currently runs 7 extra care schemes across central and outer West London. Just for those who may not know, extra care housing, we're not care homes. We provide people with their own front door. They have their own key, their tenancy agreement. But what we do is have an on-site care and support team that can flex as their person's needs may change. So this means that as someone's health or their social care needs around loneliness, or they want to get involved in activities, it means we can put in place a package that can meet those needs. Okay, so we just move to the next slide, please, Liz. So what this project showed us is that, as again, many of you will be aware, that within extra care, there's been a major shift, I suppose, over the last few years, that our care teams are continually needing to adapt to support people with increasingly complex physical, mental and emotional needs right up to the end of their life. And what that means is our care teams are working with them at points in their life when there's lots of change going on, both in terms of their health, their social care and their housing, and most importantly, their emotional needs. We're seeing a recent survey we did noted that during the pandemic, we had 50% of our residents talking about loneliness. So our care staff play a key role, as they are best placed to know the person as they are now and advocate on behalf of the individual. So what we've found, particularly through the pandemic, is that our staff are well best placed to deal with and advocate on behalf of residents' needs, sometimes alongside families, working with health professionals. But what we've also found is that sometimes their voice isn't always listened to and respected in the way that other professionals might be. The care teams seek to work very closely with GPs, district nurses, pharmacy, community mental health teams, hospital teams, social workers, and we do at every stage try and prevent admissions, and we do try and, as soon as if someone is in hospital, get them home as quickly as possible. Now that's obviously, as many will be aware, as many challenges during the COVID period. But and what we try and do is we have an integrated approach to manage complex health needs, as we have been involved in projects that have proven this has the greatest impact. As I said, the issue we've found through the project is health professionals often treat extra care as if it were nursing or residential care, and it can impact on many professionals' expectations. and sometimes they don't necessarily, as I've said, respect the voice of the care staff in the way that they might colleagues. So we just move on to the next slide.
So the Better Lives, Better Endings project, which is a collaboration between Octavia and St Christopher's, is about ensuring a continuum of high quality relationship-based care from arrival into an extra care scheme through to the end of life. Care that can ensure all needs are met: physical, emotional, spiritual and social. And this slide just really represents some of the background concepts when we were putting together the aims and objectives of the project, which we've spoken about in our case study. As Neil has already mentioned, this epidemic of loneliness that we're experiencing, particularly in the ageing population. Also some of the issues around balancing risks. So allowing a certain amount of freedom for individuals to manage their own risk and take responsibility for that, rather than allowing safeguarding to really deprive people of individual freedoms. Also this idea very much, it's something experienced within healthcare as well as social care, where everything is policy based and compliance becomes paramount over really being creative and flexible and recognising real life situations. And then very much in 2015, this idea about better endings and about identifying the right care at in the right place at the right time. So it all boils down to everyone working together to anticipate needs well in advance, nothing we all didn't already know. And only a small percentage of people will need specialist palliative care. And recent conversations that we've been having with extra care staff at Octavia showed that they recognise themselves as palliative small p care providers. And they're willing to support their residents to die in their own homes, but they need to be recognised as valuable partners, to have a clearly defined role and to be equipped with the tools to fulfil that role. Very much the trust and relationships at all levels that Neil Reveley was talking about in the previous presentation. So our published case study is just a taster. It's an interim report. At the end of this year, we hope to have a suite of resources to share with others.
I think we couldn't miss the opportunity to not reflect on the last 15 months. We've obviously seen a number of people pass away in the last 15 months. Some are approaching the end of life in this unprecedented time and have had to deal with what that's meant as they've come to the end of their lives. Some have had COVID and some have survived and then reached the end of their life. And a smaller number for us have had COVID and sadly passed away, maybe earlier on than we expected. So like all providers, we've had a robust approach to controlling the risk of infection. But what this project has given us through that time is a way of dealing with death and enabling staff to be able to cope with the death and helping people to cope with their lives as they come to the end. Also, it's also helped with working with relatives who have also struggled. We've seen the hospital system and the primary healthcare system and social care system at a real stretch during this period. So I think it's really helped us to sort of work with our staff, and Liz and Antonia, who have led the programme, did some webinar sessions during that period to help debrief staff and sort of unpack maybe some of the issues that were going on, which we've also fed into the case study. So we just move on. So what I just wanted to do was actually flag a case study that highlights, I suppose, when things have gone wrong. We do have better stories than this. We've collated a number of case studies through the project, and some have been very successful in collaboration with health, social care and relatives. But we felt this case study was necessary to point, because I think if there's one case like this, it's something we don't want to see. And we want to address the issues that that allow this to happen. So we've got had a resident, she was in her 80s, final stage dementia. She'd been living with us in extra care for several years and attended a day centre that we ran. So she was sort of in and out of the centre and sort of had a good quality of life. Had family back in Ireland, but was very reliant on Octavia and knew the staff extremely well. And the family back in Ireland relied on the staff to sort of advocate for her. I think right at the start of the pandemic, she was having chest problems and was being treated for pneumonia, was discharged from hospital. We're all aware that there was lots of pressure on the system to get people out of the hospital where possible, where they could be cared for at home. However, when she arrived at home, she arrived on a stretcher, which was an indication that she clearly was unwell. The scheme was not well equipped and the care staff struggled with her continuing nursing care, and there was an urgent review that was carried out and double-handed care was put in place, and she was slipping away. A GP was involved in making decisions, and we put in place a do not attempt to resuscitate. But as things unfolded, it became apparent that she was deteriorating very quickly. An ambulance was called, and because the end of life plan for Dee, and despite the concerns of care staff, they took her to A&E. This is a case that she should have really had the opportunity to die at home around the people who cared for her. But because that wasn't on the system, it meant that she was unable to do that and died alone. So what we're doing through this project is trying to ensure that records are on the CMC system, which the ambulance crews have access to, and we're trying to educate our staff and make sure they advocate for people to make sure that the person has the best experience right at the end of life as possible. But more than that, this is about ensuring that they also have the best life they have up until that point when they die. Let's move on. So we just thought we'd prompt some thoughts for discussion. We are all part of one system, and we should be, as previous two speakers have highlighted. We want to be part of that integrated system. There's some huge challenges there to make that happen on the ground. We're working locally with our CCGs through this project. We've got a steering group, we've got representation from the local CCG, adult social care and hospices locally, as well as working with St Christopher's. But the question is, how can we get the care sector to integrate better with the NHS on the ground? We're seeking better local partnerships, strengthening GP, district nurse, community mental health relationships. Are there ways that the needs could be met in a different way? The community matrons, some sort of frailty team that can be advising staff. We had that experience from St Mary's Hospital in Paddington during the pandemic, and by having local nursing staff on the end of the phone who could access hospital records, it really did help us to sort of make sure we coordinated care. But these sort of on the ground solutions really need to be put in place to make it work practically. How can we educate, create a better understanding of extra care across healthcare settings? You know, we're not a registered care provider, we're not a nursing care, we don't necessarily have the skills, but we do have staff who are well trained, passionate, but they are social care staff. How can care workers be better heard as advocates for people they care for? You know, is there an education needed across the system that ensures that care workers are understood, what they do, the limits maybe to their jobs and how they work, but how they can be really be made to feel part of that system? So they're just some thoughts. I mean, maybe we don't have all the answers today, but just maybe to go away and talk locally with your CCGs and social care partners. So, as I said, I'm Neil McCarthy from Octavia, and my colleague.
It's Brian. Thank you very much. Thank you for listening.
Very much for your time.
Both of you, thank you for a wonderful presentation and really demonstrating the importance of that multidisciplinary approach. But not only that, and again, as you say, it touches on what both Matt and saying, but also how to make it so personal for people as well. And that holistic, it's very easy to say it, but actually doing it and having engaged with your staff, Neil, I know, and seen some of the case studies that have come through, some really important personal qualities that your staff and the team at St Christopher's offer to maintain people's dignity at a difficult point in time. You ended with a series of questions. I don't think we can keep them up at the same time, but we do have a selection of questions in the Q&A box. And in fact, as you finished, as you drew to a close, I think there was a question for both you and Liz, and I'm just going to try and find it. I think it was from, unless it's been answered, may well have been answered. It was something about, apologies now. It was about the extra care experience from memory. Let me come, oh yes, here we are. It's from Darren Portman. Thanks, Darren, for your question. Are the on-site care team employed by Octavia a partner provider or the local authority? There may well be some people who are not too familiar with extra care housing and the planned care and the personal care that goes in. So if you can give your example, that'd be brilliant.
Okay, from Octavia's perspective, we've got a preference for an integrated model. So that's the housing, the support and the care working together. So we do that locally, and then we can obviously work with health and social care. Some other providers do in extra care, I think, do have a third-party organisation providing the care, and they do the housing. So there are different models, I think, that exist.
Yeah, no, that's fine. In fact, some of the work that Lynn has done over the years shows that there can be as many as 27 different types of arrangements that can be clustered into those integrated approaches, hybrid approaches, and segregated approaches. So, but in your case, it's very much integrated. So thanks for that. Early on, there were some questions also for Matt. Matt, I don't know if you had a chance to have a little look at those, but there were some questions around, in terms of anticipatory care, does this apply particularly to people living in their own homes, and does that include extra care housing?
Yeah, it absolutely does. So those in extra care housing, that's their own home. So, and we would then look at those that are providing care within that support to either be part of the representatives or part of the MDT. So absolutely, that they will come under the anticipatory care model.
Thanks for that. And again, a couple of other questions, one from Joanne and one from Rachel. If I just kick off with Joanne's first, will the risk stratification consider social elements as well as health elements? So that's a really great question.
Yes, so when it comes to the risk stratification, it'll be using the population health management methodologies and risk stratification tools. So it not only just covers health and care elements, it's the wider determinants of health. So that would come under, and housing would be, and loneliness would be included in that.
I think there's a supplementary question here from Rachel. Now, while the Housing LIN, and today we've talked very much around older adults, this also applies. What are those, or how does it apply, and what are the types of reasonable adjustments for people with learning disability or people with autism? Are there examples that have come through in terms of the work?
So they are a cohort that is that could be identified as part of anticipatory care, and reasonable adjustments would be included in that to ensure that the care that they are receiving is tailored towards them, because the anticipatory care is about being person-centred, so it's about the person and what care they need and tailoring that to them.
Thanks, sir. So again, it's a person's. So was somebody else coming in there? No, that's all right. I thought I heard some background noise. Is Neil still with us? Neil Reevely, that is.
Yes, Jeremy, I'm still.
I know as a former director of adult social care, issues around learning disabilities and autism would also be much on your brief as well. I was just wondering whether when you were talking about the high impact changes and the like, and also I know you chair a board of a charity as well, whether there are issues around reasonable adjustments and things we can do to improve the housing quality and choices for people with a learning disability.
I think so I think I would concur obviously with Matt's comment, particularly in relation to anticipatory care, but I would refer back to some of the comments I made in the presentation, which is about seeing this as one of a suite of things that we can use in our integration across health, housing and social care in a local place, whether that's strategically at an ICS level or locally at a primary care network level. And of course, many of us, many people on this call are already involved in improving the housing opportunities for people with learning disabilities, the Transforming Care programme, et cetera, et cetera. So for me, a lot of what has been talked about in some of the questions absolutely refer and would be included in anticipatory care. But I would also want to, in amongst that conversation, I would want people to have a broader conversation in their localities and in their regions, not just talking about anticipatory care and talk about preventative work, et cetera, et cetera. So, from some of the work we've done in the past, Jeremy, I'm very much an advocate of, not seeing institutional care being part of the future. And whenever I've been involved in creating extra care and other supported housing environments, we can absolutely replace residential care, etc. The key to whether we were able to replace nursing home care was whether we get health commissioners to commission district nursing services and community matrons, and which Neil referred to, sort of community nurses, etc., in a different way. And actually, if you just label that, that's only about anticipatory care, or it's only about learning disabilities, or it's only about something else, you might have some problems there. So it's how do you get that generic commissioning approach to say, that there's overlaps here. You can't, be very difficult to draw a straight line that says that's anticipatory care, this is something else. We need to harness the opportunity to join these things up. And in relation to one of the other questions about the tenure, I think someone said, will it apply in extra care? I don't know whether it was seen in the chat, but I tried to put a response to say, for me, these things need to be tenure blind. It doesn't matter which accommodation you live in your own home, and it needs to be. I think part of the difficulty sometimes is because of the great job housing associations, RSLs do, quite often we're better able to provide anticipatory and preventative care if you're a tenant within an RSL property. And sometimes actually if you live in your own home, or if you're with a private landlord or whatever, it's not so easy. So I think when we address these things, we need to be addressing tenure blind. And you mentioned my former role as a director of adult social services. That was in Sunderland, and we commissioned the local stock transfer organisation, Gen 2, a number of people will be aware, to do tenure blind interventions in particular areas of the city, as opposed to saying only their properties, because there'd been a lot of, Sunderland had a high level of pepper potting of where people had exercised their right to buy. And if we'd only commissioned services from them in relation to those who were a tenant of theirs, they'd be not seeing to the person next door to their tenant. And therefore, I think it's important, as we do joint commissioning with our health colleagues, we do see this as tenure blind, but there are some great opportunities working with RSLs, both in their own properties, but also supporting them as a more generalist provider, if you like, of joint services locally.
Yes, and I remember those days when you were also very much closely related to looking at outcome-based commissioning as opposed to hourly-based commissioning as well. So it's not just the tenure by, but actually looking at quality of life outcomes as well, which is really important.
Absolutely.
So another couple of questions. And actually, there's a couple from Gus and one that Andrew's just posted in, which both sort of touch on issues around health inequalities. And Gus, can I just say, I love the fact that you have a job title, or you work as a community inspirer. It's a term I've not come across, but I hope that we should see those more frequently around the country. But you also highlight very much the relationship between poverty, housing and health inequalities. And I'm just wondering, from Matt and Neil's perspective, are there issues there that you see that the role of public health and partnerships across housing and health can actually mitigate against some of those inequalities?
Yeah, so absolutely, it's anticipatory care is about that multi and cross-sector work, and it's about bringing people together to focus on the individual and the person that the care is about. It's not working in silos. So one of the principles that we insist, well, what we say on in terms of cohort identification is about looking at and reducing health inequalities and what is relevant for that area. So I would totally agree with that. Yeah.
And any work that's coming through from the CHIP programme or the like around health and housing inequalities, Neil? Or indeed, you mentioned in your slides about giving patients and citizens greater voice, which is also a point that Gus raises.
I think the health inequalities issue, unfortunately, I think in certain parts of the system, it's taken a pandemic to sort of really sort of make them even be more noticed. As we know, the pandemic is simply, well, not simply, but it's accentuated those health inequalities and other inequalities that we knew were there already. I think if there can be anything, positive that can come out of this terrible issue that the terrible situation we've had with the pandemic, is that it has shone a light on inequalities in a way that I think is now being perhaps at least being talked about, is how we better address those inequalities across the board. And I therefore think in all of our policies, we being the public sector in particular, have always tried to put things in place to address inequalities. I think people are, with the evidence of the last year, I think people are going to be redoubling their efforts in that regard.
Can I just?
Please, yeah.
I was just going to say that certainly the hospice movement is very conscious that in terms of inequalities at end of life, one of the problems is that the health and social care systems are never going to be able to mop up all the needs. And actually what we're increasingly realising, that maybe inadvertently we've over-medicalised ageing and dying, and that we need to do a lot more around public engagement, community engagement, and initiatives like compassionate communities, compassionate neighbours, and public health about what ageing is, what people need towards the end of their life is socialisation, good neighbours, support, rather than a district nurse necessarily, or a GP, or and so I think there's an opportunity here to all of this is great, but we've also got to engage people's neighbours. Then and I know that at Octavia they're very aware that is there a way of getting the community outside the schemes to make relationships with people and become part of the circle of support for people who are in their housing.
Yeah, Liz, you raise a really good point, and I see a couple of people already giving you thumbs up for that in the chat or the Q&A box. And you may not know, but the Housing LIN is hoping to run a happy hour on compassionate neighbours towards the end of July. There are, again, we'd love to involve you and Octavia in this, but also there are one or two other members of the LIN who are testing some of these models out across the country. And I think we'd love to have your views on those and that compassionate neighbour program. So watch this space. I think I can't remember the date off the top of my head, but we'll keep everybody posted. And Liz Curran, who's just I'm going to give her the last question, which is, what about the financial implications of anticipatory care? Surely it costs more to do 24-hour care at home for someone with severe dementia than in a nursing home. So Neil or Matt, do you want to come back on that, or Neil McCarthy as well?
Certainly, I'm happy to start, Jeremy, and my immediate response is not necessarily. And certainly, if you take the overall, I hate to use the term cohort, but if you take the overall cohort of people in those circumstances, then on average, it will cost less. So the evidence would suggest, some of the work the LIN has done and others, there may be individual cases that will cost more. But actually, if you're commissioning for a whole community, you need to see what is the cost for that whole community rather than on each individual case. I know you've already reported on through the LIN, Jeremy, a number of extra care housing developments purely for people with dementia. I developed schemes purely for people with dementia, but also schemes, larger schemes that had a number of apartments within those extra care schemes for people with dementia. So, and that definitely proved to be cost effective. That was required joint commissioning with health, so the health services were in there, but also people not in extra care, but in their own homes in the community, using digital technology, etc., etc. Yes, towards the, to degenerative disease, dementia, so, towards the end of someone's illness, the cost may go up, but the average cost, if you like, over the course of being supported when they've needed support, and in any case, I would argue if it's absolutely the right thing and get to the right outcomes, then we need to find a cost-effective way of doing it rather than condemning people to institutional care.
So again, thanks for a very passionate point raised by Neil there. Matt, any final comments? And then Liz and Neil, from your final comments as well?
No, totally agree with what Neil just said. It's about the person. It's not about the cost of what their care is. If its care needs to be at home, that person, then it's a cost across the whole system. So I agree totally with what Neil said.
Liz, Neil?
I think on that point as well, I think recognising the whole system cost, I mean, if someone is at home or in nursing care, is recognise, how much time do they spend in hospital? How much time does their life decline quicker? I mean, I think I'm agreeing with your point that we need to look at individuals, look at the quality of their life, and ensure that we can, make sure that they're kept out of hospital for as long as possible and that they can maintain the skills that they have. And I think particularly around dementia, we've got lots of evidence that we can support people to sort of sustain their lives for longer in a quality way. When you go into a nursing home, as you said, a lot of the evidence is that they will decline quicker and may spend more time in hospital as a result of that.
Yeah, no, that's really good. And Liz, final word from you before I sort of wrap this up.
Yes, and again, well, thinking about cost, well, if you engage communities and, certainly like the hospice movement, it's a voluntary sector to start with, so our funding comes from local communities, but also the number of volunteers that we use in hospices. But it's also about, isn't it, about, engaging, volunteering, and, being a societal issue that everybody takes responsibility for. Not just government departments.
Well, thanks for that. And I think it's also Volunteer Week, National Volunteer Week this week. So thanks for drawing attention to the important role that the volunteers play, both in a hospice movement, but also in many care and support settings. It only requires me now to really bring this happy hour to a close. It's been a real fascinating session. We've had 3 varying presentations, but I think you'll all see that we've deliberately sort of crafted this to think about different aspects around how to work closer in partnership. What are the sort of the cultural leadership and the relationship requirements needed to sort of sustain that sort of quality of life outcomes for anybody at any age. So I'm really pleased that we can see both at a national policy level, strategically, but also very much from the case study that was presented, the work of Octavia and St Christopher. So on behalf of the Housing LIN, thank you very much. And I also thank the team behind the scenes for doing what they did, both in terms of preparing for today, but also helping out with posting numerous resources and examples of practice. So thanks very, very much. If this is the first time that you've joined Happy Hour, we have 3 more in June for you. Next week, we focus very much on how a variety of housing operators are developing their strategic approach to age-friendly housing approaches, so whether that's in specialist houses or through their general needs housing provision. We then move on, for some of you who know it's Pride Month, we're looking, putting the spotlight on some of the issues that are being raised across the country with LGBT communities, in particular in London and in Manchester. And we conclude our June series of Happy Hours with looking more at about the adaptation, how we can create more contemporary lifestyle and homes for a later life, which can be adapted and future-proofed. And we're doing that with Motion Spot and some work with the Centre for Ageing Better and their Good Homes inquiry. So if you haven't come across our Happy Hours, do please join us. Thanks very much for a really great session and the contributions that all 4 of you have made. And we look forward to working with you again in the future. And in particular, Neil and Liz, I think you talked about a final report coming out, and I hope we can use another happy hour to push that out and disseminate it widely too. So thanks, everybody.
Thank you.
Thank you.